father or your uncle or your enemy. It's witchcraft. But what we are being told to assess diabetes care or any care is that you should go to the hospital to be properly what? Diagnosed and managed. Unhealthy dietary habits, she said it. We eat junks, but you don't blame the body. As we said, it's prominent, it's prevalent in low-income countries and the society and other. And therefore, we are living below poverty level. We are managing whatever we can. And any junk you see, you consume. So we should think of what we are going to do. And that was why in that section of Nigeria, in the late 90s, 98 to 2002, we started what we called a workshop and spread on dietary management of diabetes. Because as we are going to see today, which is the normal thing, we have pharmacists, we have nurses, we have dietitians, we have doctors, we have lab scientists, everybody is a member. But the key members are the diabetics themselves. And in our regime, I don't know what is happening now. The chairman of all the state or zones or chapters are made to be non-diabetics. And I was happy when I was reading this morning what happened in Oyo State. Their former chairman, Alhaji Balogun, was a diabetic for more than 50 years. And I was reading this morning, the new vice chairman for Oyo State and Southwest Zone, Elijah somebody, is 87 years old now and has been with diabetes for 49 years, which by January 2022 will be what? 50 years. So you can see it's not a death sentence if you know what you want to do. So we have to manage that. Urban dwelling, yes. When we are in the urban, you want to be Oyibo, so we eat food. But the problem we now have in diabetes is that there's no difference between urban and village. People in the area are even eating more things than you. We have thrown away all our natural resources. I know when I was small in the village, we were eating all these fruits, vegetables, all these things. Now, nobody eats it. They're looking for canned food, junks. When you are going to school, they give you money to buy meat pie. In the house, you are looking for cake. These things are things that we predispose to because once you are eating junks, what are you doing? You are accumulating the carbohydrate, you are accumulating the fat, and if your insulin is not working or it's not being produced enough, the fat aspect will now interfere with the function of the pancreas, and therefore will interfere with insulin production and action. And of course, as we see, we're now going into what we call metabolic syndrome. You now see diabetes leading to cardiac problem, kidney problem, whatever, even blindness. Advanced age, people that are old age is what? A blessing. But in Africa now, we see old age as a problem. In China, Japan, you see, we have seen people that are 100 and something years, and they have lived with diabetes for over 60 years. And the person not telling you in Oyo State, and the one that even hand over to him for 50 years. My own uncle died at 97, and they managed diabetes for over 60 years. But some people today, once they're old, they say, no, after how many years do I have? I've done what I'm supposed to do. So you refuse to comply. Instead, you say, when I finish, you die. When you die, nothing happens. But when you die, you see that the problem is there. So advanced age is a problem. You are no longer doing things you're supposed to do. You are doing most of sedentary work. You're overeating. You're overdoing so many things. And therefore, you have to take some precautions. That gets us to physical what? Inactivity. Most of us, the young ones, by diet, we drink any type of drink. Wine, juice, malt, mineral. Even in our own time, the 90s, bottling company wanted us to market them. And we said, no, your drinks contain a lot of sugar. And therefore, we cannot be your ambassadors. But I know if it is now, people will say after they're going to pay us millions, they will accept it. So physical inactivity. You move from your house into the car, your car into the office, office to the restaurant, back to the house, then you take the last bottle before you go to bed. No physical activity. These are risk factors. And that adds to overweight, adds to obesity. Next slide. So a healthy diet, physical activity, maintaining a normal weight, and avoiding tobacco use are ways to prevent or delay the onset of type 2 diabetes. On the other hand, diabetes can be treated and or its consequences, blindness, kidney failure, heart attack, stroke, and lower limb amputation, avoided or delayed with healthy diet, physical activity, medication, and regular screening and treatments for complications. Next slide. So greatest increase in prevalence occur in low and middle income countries, with Asia and Africa producing most patients in 2030. So trends in urbanization and lifestyle. Diabetes generally is a silent killer and a disease of what? I said something now, I thought you could have echoed it. Disease of lifestyle. The way you live your life will help you to manage or avoid and live strong. So increasing sedentary lifestyle, less physical demanding work, global nutrition transition. We are now moving from Africa food, my village food, to Igbo food. That's why when they say I should eat the dikaiko and they buy soup here, I said no problem. But I will not eat, which one now? Periwinkle. So increased intake of high energy, dense, and nutrition poor foods, which contain high sugar and saturated what? Fats. So 100 years after discovery, insulin and other fundamental components of diabetes care remain beyond the reach of many. Other components include tools and technologies. What are these tools and technology? Diagnosis. Diagnosis. Yes, we now have a lot of tools in name of what do you call it now? The meter. Glucometer. Many types. Both standard and what? Substandard. And which, if you add any strip to it, if there are 10 strips added, the 10 strips will give you the same result. And therefore, you need that capacity and training to be able to do the quality control. And then adding the exact number of quantity of blood, and then leaving it for the exact time it's supposed to be, and reading it at the time you are supposed to read. So there are so many things. We come to it when we are talking about capacity building. Next slide. So insulin, high prices, low availability, few produce health team. Insulin, Banting that produced insulin and introduced to the market is supposed to be what? The patent holder, isn't it? But he sold it out at only $1. And people are making millions out of it and still telling you they are not making any profit. Now, we know, the pharmacists will talk about it. The problem we have with the human insulin and the synthetic insulin, the analogs. And of course, we know that the analogs are costlier, even up to 2 to going in for. And if we are going in for, what are we doing to help people who cannot afford it? In our own time, this is the section of Nigeria, which you people can now do by having your own under the female Association of Medical Scientists. You have an education unit. Is to educate people, the type of food you do, the type of food you eat, whatever you do. In those days, the association supports people who cannot in paying for their drugs. They campaign to the government that even though we have gone to essential drugs, they have gone commercial, that these drugs should not be as high as it is. But we know now we are commercialized everything, including the water we drink. One woman went to buy pure water. When they told him the cost, they cried. That it was more than the price with which she was married when she got married. That's what they want her now to use to drink pure water, which is true. So We had Novartis. We went to Lilly and all water and all those things. So once we talk about, I will not get into that aspect. But still, we know Novartis was too costly. We went to Lilly. It looks as if it was coming down. Other things came up. Then from there, we moved from human insulin, which is as good as the synthetic. But we are going for synthetic because we are thinking of the millions we are going to make. So we have to monitor what is going on, the delivery system, if we want to help these patients to access that care. And you can do it through this association, as I'm trying to say, by helping them have a shop. In those days, we have shops in teaching hospitals and general hospitals where they can go and buy even low sugar biscuits, drinks, and the drugs. Even in Ghana, they were supporting them. When I went to Ghana in 2007, I discovered they were supporting them. And they're giving them lectures. In those days, we have diabetic clinic days. They come in the morning, we collect their sample, instead of coming to collect sample and go home. So you come that morning, we collect their sample, then we go into education. That will last for about 2-3 hours. Then you now go to the clinic. By then, your result must have been ready from the lab. That is the role of the lab scientist, to make sure the result is ready. And when he goes to the doctor, he gets his prescription, he goes to the pharmacist, he collects the drug and goes. So he spends only 1 day. That's what we're trying to do. We're trying to do management of turnaround time. But these days, they say, come, you come and do the test from wherever it's coming from. Lack of service integration and primary health care. We have 3 tiers of government, and we have 3 levels of health care. Primary, tertiary, and primary, secondary, and tertiary. And where are the people from the rural area? Is the primary. How many primary centers can handle diabetic patients? Do they have the tools? Then even when you move to general hospital, how many of them have it? Then you now move to the tertiary. Some days you come, there's no reagent, the equipment is off. I'm happy I was listening to what Dr. Onka was talking over the other radio or TV. And they were surprised. How can you say that even in a teaching hospital? And she's an assistant director in UPTH, as if he's reporting the organs, but she's talking the truth. The only the truth shall do what? Set us free. Simple tricks, even to use glucometer, you cannot get. And for every batch of sticks you buy, you must do what? Recalibrate that glucometer for it to give you a good result. Do people use it? Do they know that? And this morning I was reading what the deputy governor said. The much they reported, I don't know what she said on Saturday or Sunday. But it's one that she was trying to say they do it at the primary health care level for gestational diabetes. So you are doing it for only the people that are what? Pregnant. What of the masses who are even more than people that are pregnant? Unless everybody will not be. So what was is supposed to be established at the primary health care level if we are really ready to help these patients. There should be, even there, they don't even send any doctor. They have a small store they call lab, and then maybe the pharmacy is even part of the reception. So, and when they are doing this, they don't even consult anybody. You are supposed to build anything without consulting different professionals to make sure their needs are taken care of. Even in buying things, they just bring things and dump on you, whether they are working or not. And that is not a price. And they say, I bought this thing 20 million, and I want the money out within the next 1 year. Then you go back and ask the patient that has come to do fasting blood sugar and 2 hours postprandial and urinalysis that is going to pay 20,000 naira. Where is he going to get it from? Then he now goes to the pharmacy. They brought insulin or diabetes or whatever they brought, and they tell the price. Then after paying 20,000, you go to the pharmacy, they say he paid 40,000. So are we helping them to access diabetes care at the primary level, which is most important, which is the grassroots, where most of the people are? So inadequate capacity, as I've said, we don't have these things. Then information management, which is what you're supposed to do from what I said. Education, teaching, and counseling. Who will be my operator? So, see, supply management is still it. Local production of insulin and monitoring tools. We can't do that in Nigeria. Even worldwide, WHO is still engaging with manufacturing companies to see how they can do what? Bring down the price, bring down the cost. But we are in a capitalist what? Society. Everybody is thinking of how to make billions out of 100. He has 100, but he wants to make billion. And then we're not considering people who cannot afford. I know in my young years, as a medical lab scientist, TB patients, psychiatric patients, children below the age of 5 are treated free in the hospitals. I don't know what I see happening now. Even their drugs are given free. But we do that only when we have what? I will come to that. So, funding is the problem. Funding is a problem. And then when you have funding and you believe that it's a burden to these people that are the low-income group, then we should declare emergency. From what we are seeing in the statistics of diabetes in the world, instead of coming down, it is doing what? Increasing. And if we put the figure together, if you put the figure for HIV, malaria, TB, all of them, they're not even up to that figure. Because we have international donors. That is where we place our emphasis. And once those international donors withdraw, that program does what? Collapses. But you help somebody. If it is not you, it might be your relation, it might be your friend, it might be your neighbor. And the Bible says, do unto your neighbor as you like to be what? Done unto you, and you should take care of your neighbor. So we should diversify the manufacturing base and creating competition. Unfortunately, there's no competition. I told you, like in insulin, Novartis came in, and Eli came in, other people come, but you will discover this competition is not yet enough. Because 2 or 3 companies facing the whole world, as we are seeing in COVID now. I see in COVID now, we are now talking of producing vaccine, doing that, and we're not getting enough. And you say you need 70 million doses, and then you are still at 70 times 2 doses, but you are still having less than 5 million or 10 million doses, and you are waiting for the manufacturer. Likewise for glucose, for insulin, likewise for glucometer, likewise for the reagents you are going to use. We are being challenged as scientists to see what we can do for local production, even in pharmacy, local manufacture of all these things, so that it may be available, accessible, and what? Affordable at a very reasonable cost. Ensuring increased access to medication by prompt diagnosis, which you cannot do. I think if I come to the hospital, you will not be able to test me. And at times you want to test me, I will say, no, I don't need the test, just give me the drug. And they insist on test. He will leave you and go to a traditional medicine healer or to a drug hawker, and then they give him the compartment he will swallow. And it's moving around, and tomorrow he will slump. They said, witchcraft have killed this person. So, we have to see what we can do as a body. Under this umbrella, we are celebrating this World Diabetes Day, so that it can be made as they will have the knowledge and then now volunteer themselves. Kill the propaganda that what is happening to you is not natural. Go for spiritual diagnosis. But I'm not against it to go for spiritual diagnosis, do the correct thing. My friend, when I was doing NYSC, we were threatened while we were doing NYSC. They are told to leave the town, or whatever we see, we will take. Even the Director General of NYSC, the state coordinator, then came. We refused to go. But one of us left. We were 5 coppers. What did he say? That life has no duplicate. And even if it has a duplicate, that the duplicate is what? It's not original and can never be like the original. So, protect your life. We should use health resources wisely and allocate adequate funding to provide a full package of care. This is where management comes in. Hmm? You should think of the whole society, not as a subunit. Hmm? Uh-huh. I'm a doctor, the chief in charge. I think of only my medicine, not even the whole medicine. Only if I'm a surgeon, I think of only surgery, the theater. If I'm a cardiologist, I think of this. If I'm a, then if you're a pharmacist, you think of your area of interest. And and the last scientist, I'm in microbiology, or even microbiology, I'm into TB, dot, because there's money coming to dot. That is not good. We should have that conceptual management scale of thinking of everything. When the money comes, yes, it's not enough. I remember when I came down from Jos to Newi, they will give me 600,000 after fighting with the management. Before I finish what I want to do, they have cut it by half to 300,000. I will still go back to the microbiology camp, cut your own. Then I go back to the management. Since I have cut it, instead of 2 weeks, we now come back after 1 week. Because you are sure you are generating that money. You have your record what you are generating. But that fund is being used for what? Other things. And not for the purpose for which you are generating it. At a point, I started paying for capital purchases, equipment from my revolving fund. And instead of giving me 5 million, I was giving only 100,000. And by the time I handed over to a full-time teaching hospital staff, since I was a university staff, they have borrowed more than 12 million from that fund. And I handed over 4 to 5 million to them today. By tomorrow, there was no cover in that account again. So they wait for the day to generate money before going to buy. So we should use our fund properly. And we also appeal to the international organization, United Nations, other people that can help. The way we have been helping in COVID, helping in polio, helping in malaria, let them look at diabetes. Diabetes is a more serious health problem than most of these things. People have it, they don't know they have it. And if you have it, you don't do the correct thing, it will lead to so many complications. Blindness, cardiac arrest, stroke, kidney problem, and whatever, under the metabolic syndrome. So we are appealing to everybody to see what we can do to be able to help these people to be able to access it. Not only facing only COVID. Now that we have COVID, everybody is running about COVID. They have forgotten about other people. So let us use the same structure and system to be able to attack most of these public health menace we have. We should build up capacity, train people through health education, and facilitate with the necessary resources in the fight of preventing diabetes from growing into a pandemic in the nearest future. If it's moving from 8 million in 1990, and we're expecting that by 2045, it will be almost 700 million. So where are we going to? So, if not now, when? Prevention is better than. We should develop standards for diabetes diagnosis and care for the prevention of major non-communicable diseases. We should have a standard operating procedure so that the result we got in my clinic, in my private lab, and everything can withstand the what? Test of time. And that will be able to aid in the diagnosis and management of these patients. We should create awareness on this global epidemic of diabetes. We should strengthen the conduct of surveillance of diabetes and its risk. We can delegate our to do their area and the disciplinary research. Because when we did the dietary management of diabetes in the 90s, it took us 4 years. I've forgotten the name of the woman. She's in River State University, Dr. Somebody, in nutrition. She was also involved. We got people from all over the place. Doctors, whatever, all of us did it. But unfortunately, that document, we don't even know what it is today. So, to salvage the growing prevalence of diabetes, all discourse on various experiences in improving access to diabetes care at different levels of health care should be encouraged and supported as we are trying to do. God will bless you if we do that. We should leave it now, do it now. The time is now. Now will not come again. Thank you very much.
Can we give him a round of applause once again? Thank you. In fact, if Professor NNAMAH did not end the way he ended, I would have asked him the question. Because they brought him here to answer that question. If not now, when? So what is the answer? Now. So thank God he answered the question. Thank you, sir. Thank you for answering the question. Ladies and gentlemen, it is a very serious matter. That is a keynote. And what the keynote does is to set the pace for discussion. And I know there are other lecturers who will dissect and give us the details of what the keynote speaker did not give to us. I want to all right. Thank you so much. Let me also inform us that this meeting is on record live on YouTube. Put your hands together for the organizers. It's live on YouTube now. After this program, you have the liberty of watching the program from now to the end of your life. We don't want you to hear these things and forget. We don't want you to hear these things and forget. That's why we put it on record. So that when you go home, you can always listen to it. I would like to listen to Professor NNAMAH when I get home, because I will play this on YouTube and listen very well. Let me also tell you as the chairman that nobody is permitted to leave this place until we end this program. Who is talking when chairman is talking? So I don't want you to leave. Your certificates are with you. If you leave because you have your certificates, you only want 2 credits CPD, you shortchange yourself. What we are talking about is information. So once again, can we give Professor NNAMAH a round of applause? And to honor him for taking the pains to travel. I don't know where Professor NNAMAH is living, whether it's in Newe or Nichao or it's in Jos, because sometimes he's everywhere. There was a time he was in Sokoto. There was a time he was in Meduguri. There was a time he was in Jos. So sometimes, even now, I don't even know where Professor NNAMAH is staying, but in Nigeria. But I know he lectures now at Nnamdi Azikiwe University. But he has traveled all the way to this place to deliver this lecture. So the association feels they want to honor him with an award. I want to call on the chairman of the chairman of the Association of Female Medical Laboratory Scientists of Nigeria, Dr. Mrs. Teresa A. Jeremiah, to come and present, do the presentation to him, what they have brought days before now. Thank you.
Thank you, Chairman, for giving me this singular opportunity. But I want to sublet. I want our mommy in the house to do us that pleasure of making this presentation to our prof and keynote speaker. Dr. Mrs. Nduku, please, can you come and make this presentation for us? Thank you, ma. Our prof, we are really honored by your presence. Thank you for the lecture. I know that with your presence, we are just covered. And and by the grace of God, we are able to get what we actually need to get. And I think that after now, I think our mindset is really changed. Thank you so much for the presentation. Please, can we encourage our mommy as she comes up? Our mommy in the house. Is she not looking beautiful? That is why we say beautiful, intelligent, and adorable. Please, it's our singular pleasure, mommy. You make this presentation to our keynote speaker.
Good afternoon once more, everybody. On behalf of Association of Female Medical Lab Scientists, to appreciate you. You talked so well. In fact, I think you have been in business for a long time. So, sir, may you have. And may God continue to bless you in your ways and the way you talk to people. And I pray what you have just told us today, you will take it to communities. You enlighten them on our behalf. Thank you very much. And as you go back, may God lead you safely home. Thank you. Yeah, also it's a certificate as a mark of appreciation. Thank you, sir.
God bless you.
Distinguished guests, ladies and gentlemen, it's been a wonderful moment, and I want to believe we are all enjoying ourselves and also enjoy the lectures. Once again, put your hands together for yourself. After the keynote speaker, we want to take the next presentation, and to take us through the next presentation is no other person than Dr. Edna Ada Igwe-Williams. She's speaking on current trends in differential diagnosis of type 1 and type 2 diabetes, the role of the medical laboratory scientists. Please, let's put our hands together as she comes up to take the rostrum. You're welcome, ma'am.
Good morning, my dear, beautiful, intelligent, and adorable, beautiful, intelligent, and adorable dear. I'm so happy to be in your presence today. I want to specially thank the executive, the chairperson, my sister, Dr. Mrs. Teresa Jeremiah, the LOC chairman and her entire team, and the entire BIA Association of Female Medical Lab Scientists in Port Harcourt. I am one of you, and I'm here as one of you. So my job is to bring this topic home. What is our role as medical lab scientists in combating this disease or disorder called diabetes mellitus? Any problem? So what can we do in our little way, in our various places of abode, our private labs, our public labs, even in our institutions where we're practicing? What can we do? What is our contribution as medical lab scientists? Of course, we're all familiar with the definition. What is diabetes mellitus? It's a chronic or a group of chronic metabolic disorders, what holds them together is the fact that they're all characterized by chronic hyperglycemia and glucose intolerance. And we've all been given a lot of data by our respected Prof about the prevalence of diabetes mellitus. As at 2014, we have as much as 422 million people suffering from diabetes, and it has definitely grown by now. And what is even more disturbing is that there's also a projection that as much as 27% of diabetics worldwide are not even diagnosed. So that is where we come in. Why are we not diagnosing this disorder? Because diagnosis is the first step to treatment. Why are we not diagnosing? And apart from diagnosis, as medical lab scientists, we're equally supposed to be actively involved in screening. So we don't even wait to see symptoms before we make our contributions. We should be actively involved in screening from all our little corners, our labs. And we should also be involved in management of diagnosis. So these are some of the things I'll be talking about today. Next slide, please. So we begin by etiologic classification of diabetes mellitus. That's classification on the basis of cause. As I said earlier, diabetes mellitus is not just one disease. It's a family of disorders. And each type has a different cause. So if you're unable to do a proper differential diagnosis, it is already a flaw. That means that proper treatment may not be given to that patient. So what are the basic types? We have the type 1 and the type 2. Type 1 is just about 5 to 10% of the population, while the type 2 is a more common type. About 90 to 95% of people have this type. We also have some other types that I'll briefly mention, other types of diabetes. Type 1, the major cause there is that the beta cells, which is where insulin is produced, is destroyed. So there is an absolute or near absolute presence of insulin, and that is what gives rise to the disorder. Because if insulin is not there, that is the hormone that is responsible for uptake of blood glucose. If it is not there, that means that we have hyperglycemia. There is increased blood glucose in our blood. So for type 1, there is a destruction of the beta cells, and because of that, insulin is not adequately produced. And we also know that this destruction comes about because of an autoimmune disease. What is that? The body's immune system is fighting against the beta cells and the insulin and destroying them, seeing them as foreign and destroying them. So that is the genesis or the pathophysiology of type 1. So there is autoimmune disease, and that is why in the blood of type 1 patients, you will find autoantibodies. You'll find autoantibodies against insulin and against beta cells. Also, type 1 has an acute presentation. It's, you can see symptoms within a few weeks or months of onset. So it has an acute presentation, and the treatment is usually insulin dependent. And of course, we all also know that it's mostly found in the young people. It's juvenile onset. But having said this, the thing about diabetes, none of these things is so solid. There is a lot of interplay between type 1 and type 2. coming to type 2, this is the one we say is maturity onset, and it's a more common one. These ones are not genetically predisposed to diabetes. Diabetes comes on mostly as a result of lifestyle issues. So it's usually based on insulin resistance or depressed insulin secretion. So what do I mean by insulin resistance? Normally, I said insulin is responsible for uptake of glucose into the cells from the blood. Now, for type 2, we have insulin there, but the receptors are not sensitive to insulin because of certain things that have gone wrong. And the main reason is that, in fact, the main predisposing factor there is obesity. And it has been found from several studies that in obese people, there is chronic inflammation. Chronic inflammation. And one of the things that chronic inflammation does is that it affects the signaling system in these individuals. So insulin is there, but it's not able to perform its function of signaling glucose transporters to carry the glucose into the cell. That is why it is said to be insulin resistant. So insulin is there, but it cannot perform its function because it has become insensitive, and therefore glucose is not transported into the cells. And because, of course, there are several predisposing factors, as Prof has already told us. I'm just highlighting one of the main ones, which is obesity. There are other predisposing factors. What all these predisposing factors do is that they enhance the insulin resistance, which is a primary fault in type 2 diabetes. So you will also find that these individuals, because it's not an autoimmune disease, you will not see autoantibodies in their blood system. So it's not immune mediated. Also, the symptoms are gradual. For a lot of people suffering from type 2 diabetes, you may not even see symptoms for a long time, for years. They are asymptomatic. So for such individuals, we will go through how you can screen them. So it's not always the best to wait and see symptoms before you screen for diabetes. There are certain indicators that we can easily do in the lab that will help us know people who are eligible for screening and those who are not. So for most of people with type 2, they are asymptomatic for years before they eventually, Then coming to how they're treated, most times is based on lifestyle changes. I'm sure the dietitians will tell us more about that. Exercise, oral hyperglycemics, and so on. And then it's maturity onset. Next slide, please. Okay. So I mentioned other forms of diabetes. We have gestational diabetes, and somebody is here to do justice to that, so I won't talk about it. We also have some rare genetic disorders like maturity onset diabetes of the young. In fact, this one mimics type 1 diabetes, but it's actually not type 1, because when you screen, you will not find some of what you find in type 1. Then we also have latent autoimmune diabetes of adults. So this is now type 2, but if you screen, you will find autoantibodies. That's why I say there's a lot of interplay between the different forms of diabetes. And the best way to diagnose is just to test. There are some others. Then we also have diabetes that comes from secondary causes. You all know that there are some hormones that are diabetogenic, sorry. There are a number of hormones that are diabetogenic. So any disease involving any of these hormones will ultimately also result in diabetes. Next slide. Now, what are the symptoms? Symptoms are quite deceptive sometimes because almost all forms of diabetes have the same symptoms. So it's not easy to do differential diagnosis based on symptoms. For most cases, you will find that there is polydipsia, which is increased thirst. There is polyphagia, increased hunger, blurry vision, polyuria. You know, these are symptoms that we bring people for testing. Once they see those symptoms, they come to the lab or to the hospital to get tested. So it occurs in virtually all types of diabetes. But as I had earlier said, in type 2, sometimes those symptoms take time to come up. And the stitching time is always better. So for those people, there are ways we can screen them even before those symptoms come up. So these are the symptoms. Also, there is tiredness, fatigue in the hands and feet, sores that take long to heal. For type 1, unexplained weight loss. For type 2, obesity. Then, there are different kinds of patients that come to us for diagnosis. We can have patients who are in crisis, diabetic crisis. Some of those patients are rushed to the hospital. And in most cases, it's as a result of diabetic ketoacidosis or diabetic osmolar crisis. So the doctors handle those patients and quickly knock them down to normal. But for us, laboratory scientists, most patients that we will see are either symptomatic or asymptomatic. So what do we do with symptomatic patients? What tests? I believe we're all familiar with these ones. Fasting plasma glucose. That's the normal range, and we begin to worry when it's more than 7.0 millimole per liter. But when we have values between 5.5 and 7, we look at that area as pre-diabetes. So whoever is falling in there should actually be screening regularly while making effort to get back within the normal range. Then we also have, for fasting, of course, we know that it's an overnight fast that is essential for that test to be done. Random is not diagnostic. That's why I have not put it here. Then 2 hours postprandial or OGTT is usually recommended. And that's the reason for OGTT is that it gives you the complete picture of what is going on between the 2 hours period. You see the rise, you see the fall. But unfortunately, it's cumbersome and not very pleasant. So a lot of people don't like it. So you will find that often we do more of 2 hours postprandial, which will still give you the useful result you want to know, which is the fasting value and how well the body has handled the load after 2 hours. Ideally, it should come down to the fasting level. But where it is still hanging, it means that the person is diabetic. And of course, for these 2 tests, you give the patient a load, a glucose load, 75 grams in 250 mils. Some people ask the patient to go and eat. I really do not like that one. Because as scientists, we should control. A situation where a patient goes somewhere, you don't even know what the patient ate. It's not very, very good for quantitative work. So ideally, these are the ones we should do. So these are to diagnose a patient who has come to your lab with symptoms. And then you recommend these tests and you do them. And if you get positive results, the ones on the right, you know that it's positive. The last one, HbA1c, is often more done for management of already diagnosed patients. Because you want to see the picture, the blood picture within the past 2 or 3 months. How well is this diabetic patient managing his or her blood glucose? So that's why we do that, and ideally it should not be more than, this, can you go back? Ideally it should not be more than 6.5%. Anything more than that is an indication of poor management. Next one, okay? Diagnosis of asymptomatic patients that I talked about. There are certain screening guidelines that we can follow to help diagnose these patients on time. For instance, anyone with a body mass index higher than 25, regardless of the age, and has additional risk factors like high BP, abnormal cholesterol levels, sedentary lifestyle, history of polycystic ovary syndrome, heart disease, or who has had a close relative with diabetes, that person is a candidate for screening. As medical lab scientists, we can actually be determining BMI in our labs. All it takes is a ruler to measure the height and a scale to measure the weight. So you can assist with prevention by constantly doing BMI free of, I do it in my facility, free of charge, and you'll be surprised of, how many unknown or undiagnosed diabetics you will come up with. Even BP, we can be checking. And when you have people that are compromised in these areas, you suggest the test. That's a diagnostic test, fasting blood sugar, to them. So that we can play a little role in actually catching or nipping the problem at the initial stage. You don't wait for that person to come down with diabetes, knowing how our economy is. Because diabetic care is very difficult. It's expensive. Not everybody can afford it. That's why they call it rich man's disease. But we can help to, nip the bud at the, onset by running some of these things. Also, anyone older than 45 years is advised to do regular screening. In the textbooks, they said it's 3 years, but I personally advise yearly. You can take it as your New Year resolution. Every year, you just go and monitor yourself. Do a complete checkup, not even only diabetes. There's so many things we should check. And in that way, if any of these things are coming up, they can be checked before it becomes a problem. Next one. Also, women who have had gestational diabetes, which is diabetes during pregnancy, often they are predisposed to developing diabetes later in life. So it's also advisable for them to be screening regularly. I think our resource person will tell us more about gestational diabetes. Then anyone who has been diagnosed with pre-diabetes is advised to also screen regularly. Now, talking about this screening, I know that as medical lab scientists, for proper diagnosis, we really should use colorimeters, spectrophotometers, or chemistry analyzers. Glucometer, if you have it, is for screening. So, if you screen with glucometer, it is important to confirm with the appropriate equipment. Glucometer readings are not diagnostic. It's for screening. So if you don't have the capacity to do chemistry the way it should be done, please collaborate with some other labs that are doing chemistry properly. And the reason, as you will come to find out, is that glucometer readings are much higher than spectrophotometric or colorimetric readings by as much as 20 to 25%. I have done it in my facility, and it's there in the textbooks. You can go and Google it. 20 to 25% higher. So you should not run into the risk of declaring somebody who is not diabetic because you're using glucometer. Ideally, it's for screening, it's for the doctor's side room, and is equally for the diabetic patient to monitor herself at home. And the proper thing is that when a diabetic patient gets that kind of reading at home, the person should come to the lab for confirmation. That's the proper thing to do. And above all, please don't treat. It is highly dangerous for somebody who is not medically qualified to treat a disease as delicate as diabetes mellitus, just because you want the money. Let us have our professional boundaries. Do your work and refer the patient to an appropriate doctor who has the benefit of getting the patient's history and so many other things that we don't do. And as a whole, the diagnosis can be done. Diagnosis is not just based on lab results, especially for this disorder. So coming to the crux of the matter now, most of us can do initial diagnosis, but a lot of us don't know anything about differential diagnosis. And as I've already said, most of these tests that are here are not even routinely done. They're not routinely requested. But I am hoping for a time when they will be more routinely done, so that we can properly diagnose diabetes mellitus. Now, why am I saying this? There are sometimes symptoms and even case file, family history, everything may be pointing in one direction. But by the time you do differential diagnosis, you have a diagnosis with certainty. And it is very, very important to know the cause of diabetes so that you can apply the appropriate treatment. So if somebody is diagnosed as type 1 now, that person, they will start pumping insulin into that person. Sorry, as type 1, when the person is type 2. In type 2, insulin is there. So you don't need any extra insulin. In fact, in type 2, there's even excess insulin. Because of the resistance, the fact that glucose is not being taken up, the excess glucose in the bloodstream is causing feedback stimulation of the pancreas. And the pancreas is continuously stimulated and it keeps producing more and more insulin. So you have insulin in excess in type 2. And of course, that's why you have high C-peptide. C-peptide is simply a product that is produced alongside insulin. Insulin is produced from pro-insulin, and when pro-insulin is broken down, it gives you insulin and C-peptide. So C-peptide is, high C-peptide is an indication of high insulin. So you find that in most cases of type 2, you have high C-peptide. So if the person is not giving insulin again, that's an overkill. And it can kill, you can have a hypoglycemic coma. It's an overkill. So diagnosis is key to the right treatment. So in type 1, you have low C-peptide. And C-peptide is actually preferred to insulin because it's more stable. It's a more stable substance to determine in the laboratory. So low C-peptide is found in type 1, while higher C-peptide is found in type 2. So that's a way of differentiating the two. Also, the presence of insulin or islet cell antibodies, you will find it in type 1, but it will not be there in type 2 because type 2 is not an autoimmune disease. And there are kits available in the market for all these tests I'm talking about. There are kits for autoantibody determination. There are kits for C-peptide determination. That is an ELISA method. Then the presence of urine ketones is more associated with type 1, which is usually more severe than type 2. Although, as I said, in poorly controlled type 2, it can also get to that stage of giving you diabetic ketoacidosis. So you can find it in both, but it's more commonly found in type 1 diabetes. Then we also have genetic markers. You know that type 1 has a genetic origin. It's usually found in families, you know. That's why family history is so important in the diagnosis of diabetes. So you will find that doing tests, genetic tests to identify genetic markers, you know, such as HLO, genotype testing and all that is useful. But as I said, most of these tests are not routinely done for now, but they can be requested in special occasions. But where some of them have found more application is in identifying people at risk. For instance, autoantibodies and genetic markers have been used to just screen general populations to find out individuals who are at risk of developing diabetes later. Like in type 1 diabetes, patients have been known to carry these autoantibodies for years before they come into clinical diagnosis. And, you know, in fact, normally clinical diagnosis comes up when there's a trigger. Maybe there's a viral infection or or any other environmental trigger. But they carry those autoantibodies from childhood. So if you're able to identify people with those autoantibodies or genetic markers, you can equally prevent the onset of clinical diagnosis by watching. Maybe the person begins to manage his or her lifestyle, knowing that there is a predisposition to developing diabetes. So what I want you to take away today is that diabetes is not a death sentence. It is manageable. In fact, I know a professor, as far back as when I was very young, he has been diabetic. He has so managed himself. His wife that used to take care of him has died. He is still alive. He's a professor in Uniport. He should be about 100 or so now. And he has lived well. So we have our role in helping to prevent diabetes, to diagnose diabetes, to manage diabetes, so that we can have a diabetes-free society as much as possible. Thank you.
That was a very wonderful presentation. Please, once again, let's put hands together for her. We'll use this opportunity to present an award to Dr. Edna Ada Igbegbule. We'll call on the Chairman, Association of Female Medical Laboratory Scientists of Nigeria, Rivers State branch, to help us with the award. Okay. To present the award to Dr. Mrs. Edna Ada Igbegbule is one of our own, the National Vice President, Gates of Medical Laboratory Scientists, South is no other person than Pastor Dr. Chinedum I. Solomon. Please, let's put our hands together for him. You're welcome, sir.
It's a privilege. Of Female Medical Laboratory Scientists of Nigeria award of recognition for selfless service and as person presented to Dr. Edna today, 18th day of November 2021. Madam, you are welcome.
Thank you. Thank you very much.
Thank you very much. At this point, we want to also recognize and make welcome our council representative. He is no other person than Scientist Romeo Minini. You're welcome, sir. We recognize you. Very fine and handsome young gentleman in his capacity. You are doing well, sir. Sir, you are where you're doing well. You are welcome. Now we want to also inform us that this program is streaming live on Solve TV NG. If you just go to your browser, type in Solve TV NG or World Diabetes Day 2021, you also stream it live. The next is a brief break to visit to exhibition stand. At this point, it's important we take a brief 10 minutes. Just take a walk, check the exhibition stand, and we'll also give the council rep some minutes to also address us. Scientist Romeo Mini, you will have this time before they take the walk to address us. If there is light refreshment, you can also distribute what you have for us so we can take all within 10 minutes before we resume for the next presentation. Let me just prepare our minds for the next presentation. We will be having Dr. Don Onguli that will take us through COVID-19 and diabetes. The mind, the facts.
Thank you very much. Standing on the existing protocols, I want to say that I'm representing or standing on behalf of the governing body, Medical Laboratory Science Council of Nigeria, the registrar, Dr. Tosan Ehabo, and then the entire staffs of Medical Laboratory Science Council of Nigeria. BIA. You know, when my mother, she's my lecturer, she was giving us the lecture, and then I was like, I know definitely she will do justice to this very topic. Because I was a student, and then she supervised us on sugar and glucose. Not only that, she said we should compare honey and sugar. Why is it that some persons prefer honey to sugar? You know, so after doing all the necessary things, and in my literature review, we found out that the benefits of honey cannot be overemphasized. So, Ma, I thank you very much for that wonderful thing you've done for us. Personally, you are my supervisor, and I really appreciate it. Okay, we also want to draw your attention to MLSCN Port Harcourt Zonal Office, because we've observed that a lot of persons don't know that such office is existing. Please and please, for your licenses, for accreditation of other things, and anything that have to do with the Medical Laboratory Science Council of Nigeria, please do well to visit us there in number 34 Emekuku Street, D-Line. Please do well to do that. And then I also bring this message from the council to us. It's very important. The council from the research department and planning is asking for all the biodata of all practitioners of medical laboratory science, whether a scientist, assistant, technician, whatever, please try as much as possible. Want your biodata. So we've met some 1 or 2 persons, the heads in chapters and presidents and all that. Please do well, cooperate with them, get and fill the data to us for planning purposes, for research purposes. Thank you very much, and God bless you.
Thank you. At this time, please, can we just stand up just for 1 minute and stretch your leg a little? Just don't move from your seat. Just stand up and just stretch your leg. You have been folding it for a long time. It's all right. I think it's okay now. You can sit down. You can sit down. Thank you. Don't worry. Don't worry. We'll have the break. We'll have the break. Please, I know somebody has been called to come up, but there are information I have, some information I have as the chairman, which the MC do not have. And so when it clashes like that, my own supersedes. So we have a lecturer from outside who is going out for another engagement very soon. It will clash with another engagement that she has. So I want to please ask our brother that has been called to just give us a little time. He's not going to spend so much time, maybe around 15 minutes, you'll be done with her lecture on gestational diabetes. And that is Mrs. Elera Elechi. So I hand over to the MC to properly introduce her so that she can have her lecture and then leave. Thank you.
Okay. The next presenter, like the chairman of the occasion has said, is gestational diabetes pattern, risk factors, and control by Mrs. Elera Lale Elechi. You're welcome.
Thank you so much. Thank you so much, Mr. Chairman, for this opportunity. BIA. BIA. Permit me to stand on existing protocols. Good afternoon, distinguished ladies and gentlemen. I want to talk on gestational diabetes. I am a nurse by profession, and I work with a lot of pregnant mothers. So I see it every day. Some of them, you see their blood sugar will just rise, and this is a good opportunity for me to also educate others so that they can talk to their sisters, their wives on what gestational diabetes is. Next slide, please. Gestational diabetes, the short form GDM, is a disorder that is characterized by abnormally high glucose level in the blood. And the peculiar thing about gestational diabetes, just as the name implies, gestational has to do with pregnancy. It is that it is seen in pregnancy. Most people that have that gestational diabetes, prior to this time, they don't have diabetes. But when they get pregnant, during the checks in the clinic, they will find out that their blood sugar level goes up. This disease has a 30-70% chance of recurring in subsequent pregnancies. So it's very important as clinicians, as medical people, for us to really take care in managing these our patients. Because if it's not properly managed, you see that in subsequent pregnancies, it could reoccur. Gestational diabetes is said to complicate approximately 10% of all pregnancies worldwide. It is defined as glucose intolerance of variable degree and is often discovered during the second trimester of pregnancy, especially 24 to 28 weeks. In pregnancy, we actually have 3 trimesters. We have the first trimester, we have the second trimester, the third trimester. So gestational diabetes is diagnosed at this time between 24 weeks, which is 6 months, to the beginning of 7 months. Next slide, please. Gestational diabetes also sets a condition in which hormones produced by the placenta prevents the body from using insulin effectively. When our last presenter was giving her talk, she talked about insulin resistance. There are hormones that are produced by the placenta in gestational diabetes. Now, these hormones, what they do is like they try to change the normal physiological pattern that takes place when a woman is pregnant. They now alter it somehow. So now the cells cannot take up glucose. You now find out that there is a lot of, there is increased glucose in the blood. The cells can't take it. So they alter that system. So that's actually what happens. And the hormones are responsible for that. Though other things could also be responsible. Next slide, please. Causes of gestational diabetes. Like I said earlier, it occurs when the body can't make the extra insulin during pregnancy because of the resistance. The body now can't meet up. Because of the resistance, being unable to take up the cells being able to do their work, there is so much sugar in the system. The insulin now is trying to cope, trying to even produce more insulin. In some cases, it's even increased by 1.5 to 2 times the size, the number, the quantity of insulin that should be in the system. So that's what happens. That's one of the causes. So it makes it difficult for the body to cope. Insulin is a hormone, like we've all heard, made in the pancreas. It helps the body use glucose for energy and helps control the blood glucose level. During pregnancy, the body makes special hormones and goes through other changes, such as weight gain. Because of these changes, the body cells don't use insulin well, a condition called insulin resistance. All pregnant women have some form of insulin resistance during late pregnancy. Most pregnant women can produce enough insulin to overcome insulin resistance, but some cannot. Like I said earlier, some people cannot cope with it. So they now develop this condition, gestational diabetes. Next slide, please. What are the risk factors? Pre-diabetes. Pre-diabetes is a condition whereby an individual's, as I'm talking about women now, a woman's blood sugar rises slightly above normal. It's not as if she's diabetic, but it's above normal. So we term such cases as pre-diabetes. And such cases, if they are not managed properly, they actually develop diabetes, especially type 2 diabetes. Overweight, obesity, our last presenter really stressed on obesity. Family history of gestational diabetes. In the introduction, there is this chance that any woman that has had gestational diabetes before can have it in subsequent pregnancies. So it's something to actually be cautious about. Then having given birth to an infant weighing more than 9 pounds, which is approximately 4.08 kg. You know, some people take pride in the fact that they have big babies. But it's not actually healthy. See a woman, I don't want my children to be small. No. You're just paving the way for having even type 2 diabetes in the future. Age. Polycystic ovarian syndrome. This condition is a condition that has to do with the hormonal system. The ovaries, they have cysts in them. They alter some functions. And one of the things that happens in PCOS is that there is increased sugar in the system. So if a woman already has PCOS, she's a candidate for gestational diabetes when she gets pregnant. Race. It is said that African women, American Indian, Asian American, Hispanic, that's Latinos, they have higher risk of developing gestational diabetes. Hypertension, the personal history of gestational diabetes. I mentioned it earlier. Next slide, please. What do I mean by pathophysiology of gestational diabetes? Most of us here are medical people, so we understand. But the ones that don't understand, pathophysiology has to do with like altering the normal thing that happens in the body. Going not normal anymore. That's what pathophysiology is. The exact pathophysiology of gestational diabetes is unknown. One main aspect of the underlying pathophysiology is insulin resistance, where the body cells fail to respond to the hormone insulin in the usual way. Remember what I said? I said in pregnancy, hormones are produced by the other hormones are produced by the placenta. They now alter this normal physiological process. So that's what happens in this condition. Several pregnancy hormones are thought to disrupt the usual action of insulin as it binds to its receptor, most probably by interfering with cell signaling pathways. What are cell signaling pathways? It's just the normal chemical response of the cells. You know, they have their normal pathway where they take up insulin. But they alter them. These hormones now alter them because of the processes that takes place during pregnancy. Insulin is the primary hormone produced in the beta cells of the islets and Langerhans in the pancreas. Insulin is a key factor in the regulation of body's blood glucose level. Insulin stimulates cells in the skeletal muscles and fat tissues to absorb glucose from the bloodstream. I've said this before. In the presence of insulin resistance, the uptake of blood glucose is prevented and the blood sugar level remains high. The body then compensates by producing more insulin to overcome the resistance. In gestational diabetes, the insulin production can be up to 1.5 or 2 times than is seen in normal pregnancy. You know, the body has a way of trying to compensate when something goes wrong. So that's what happens here. Okay, this insulin, the glucose is not being taken by the system, by the cells. Now the body is saying, could something be wrong? Let me bring in more insulin. So that's what happens here. Next slide, please. The glucose present in the blood crosses the placenta to reach the fetus. The fetus is the baby in the womb. If gestational diabetes is left untreated, the fetus is exposed to an excess of glucose, which leads to an increase in the amount of insulin produced by the fetus. The fetus has his own capacity now to also produce insulin. So because of the high level of glucose in the mother's system, it passes through the barrier and gets to the baby, the fetus. So the fetus, because it's so much in there, it produces its own insulin to try to counteract that action. As insulin is being stimulated, growth is there. This means that the baby then develops a larger body, which we term macrosomia, than is normal for their gestational age. So much sugar in the system. Insulin brings about excess growth. So you see that the baby is increased. Is larger than normal. Once the baby is born, the exposure to excess glucose is removed. However, the newborn still has increased insulin production. Hence, the susceptibility to hypoglycemia, which is low sugar level after birth. When the mother's blood is cut off from the baby, of course, the blood sugar level will drop. But remember, the baby was producing his own insulin. So in doing that, that is why, I'll talk about that later. That is why when a child is born to a mother that has gestational diabetes, you look out for what we call hypoglycemia. If not, that child will just even have seizures because of the low sugar in the system. A pronounced physiological decrease in peripheral insulin sensitivity occurs as pregnancy proceeds. The decrease is mediated by a number of factors, such as increase in the levels of human placental lactogen, estrogen, progesterone. These are the hormones that helps in aggravating that process. In addition to altering components of peripheral insulin signaling cascades, they also activate various mechanisms enhancing cell function. Next slide, please. What are the symptoms of gestational diabetes? Symptoms of gestation, they include excessive thirst. Though, like our last presenter said, there are some cases that you might not even notice it. You just notice when the woman comes to the clinic, you just notice that her blood sugar is very high. Excessive thirst with dry mouth, frequent urination, recurrent infections. You see the woman comes to the clinic, every now and then she has candidiasis, she has yeast infections. Check for high glucose in her system. Screening tests for gestational diabetes. Initially, when patients come to us in the clinic, we have our initial test that we do. We check their blood glucose, just normal routine test. But when you see that at every clinic it is persisting, you now go further to do this test. We refer her for such tests. And the first one we refer for after the fasting and all whatnot is glucose challenge test. This involves drinking a syrup of glucose solution, measuring blood level, sugar level 1 hour later. Blood sugar level of 10.6 millimole per liter or 190 milligram per deciliter indicates gestational diabetes. Blood sugar level below 140 is usually considered normal in a glucose challenge test. Next slide, please. The second screening test that we send our patients for is what we refer to as oral glucose testing, tolerance testing, OGTT. This is sequel to the initial test. And in this case, the sugar solution that is given to the mother is more sweetened. And instead of the normal 1 hour, is 3 hours now. And when this test is done, 2 out of that result, if it's high, is a confirmation of gestational diabetes. Next slide, please. What are the complications of gestational diabetes? To the baby, excessive birth weight, macrosomia, shoulder dystocia. This can also come in for the mother. What is shoulder dystocia? The baby's shoulders are so wide, it cannot pass. You see the woman is there, and she'll end up having a cesarean section. A greater risk of jaundice. There is increased destruction of red blood cells. Preterm respiratory distress, hypoglycemia. Severe episodes can lead to seizures. Have you ever found yourself in a situation whereby you're so weak, you're tired, you've been under the sun, you've had a long day? Do you know that because you have hypoglycemia, you start feeling dizzy? Yes, it happens to people. By the time you take a drink, sometimes even water can even just calm you. But you see that by the time you eat something, you start feeling better suddenly. That's what happens. So when we have such things, complications to our baby, we are trying to guard against this thing, hypoglycemia. It is very fatal to babies. Then, obesity and type 2 diabetes later in life. As a nurse, we always advocate exclusive breastfeeding. But you know, some mothers will come to us, I want my baby to be very fat. They don't know that that is not the trend anymore. They will pump the baby with formula feeds when you can give breast milk that is in the right proportion. We are advocating for exclusive breastfeeding. It will also help in such cases. Stillbirth, birth injuries, placenta abruptio. Placenta abruptio is a condition whereby the placenta detaches from the woman. The baby is there. All these are just as a result. There are a lot of complications that go with gestational diabetes. Birth defects. Then to the mother, low blood sugar, preeclampsia. What is preeclampsia? We also call it toxemia in pregnancy. There is increased blood pressure. The woman's blood pressure increases in pregnancy. When a woman's blood sugar is abnormally high, you know, the body has a way of just trying to compensate in different forms. That will lead to high blood pressure. And it's called preeclampsia. Because before you know it, it's affecting the kidneys. There's protein in urine. There is pulling at her ankles. Is a serious condition that no woman wants to find herself in. Development of type 2 diabetes in the future. Our last presenter also talked about that. Surgical intervention. This woman, because of the complications of gestational diabetes, her baby, first of all, might become very big. She can't bring out that baby normally. She didn't plan for a CS, but she has to go through CS. Premature delivery. Trauma during delivery. Lacerations to the baby. Maybe they told her to come for cesarean section. You know, there are a lot of people that will say, not my portion, not my portion. She will now go somewhere. You want to push out a 4.5 kg baby. Meanwhile, you're not capable. Your body is not ready for that. She'll have lacerations. And she can tear up or down. If she tears up, before you know, she's having issues with leaking urine. If she goes down, it has to do with the rectum. There are a lot of. How do we manage gestational diabetes? To the mother, dietary changes. Thank God we have our dietitians here. They are going to really stress on diet. But it involves reducing our carbohydrate intake, high protein intake, increased fruits and vegetables. Our lifestyle changes, low impact exercises, For a pregnant mother, we advise them, just take walks. Swimming also helps. Then also medicines, insulin, oral agents. We have the tablets, we also have the insulin that we give in the management of gestational diabetes. Then another way of managing in the case of the mother is prenatal obstetric management. All this involved just has to do with like scan management. When you send your patient for scan, there are a lot of things that are identified, and we want to know, how big is this baby? What's happening to the heart rate? These things are seen when we send the baby for such investigations. Next slide, please. To the baby, I mentioned earlier, I was very particular about hypoglycemia. So frequent blood glucose checks. Early oral feeding, especially, preferably breast milk. Intravenous glucose solution in some cases, whereby you see that the baby is all so hypoglycemic. You give IV fluids quickly so that you prevent seizures. Preventing respiratory distress. Next slide, please. How do we prevention and control? There are actually no guarantees when it comes to preventing gestational diabetes, but the healthier habits a woman adopts, the better. Eat healthy foods, foods that are high in fiber, low calorie foods, fruits and vegetables, brown rice, oatmeal, and watch portion sizes. Some people will say, I won't eat in the morning. Then when they eat in the afternoon, they are eating 3 times. You're not watching your portion sizes. You want to compensate for the one. You just went on a fast. Okay, let me do 0, 1, 1.5 or so, as they will say. But when you want to eat one meal, it's so much. So watch portion sizes. Strive for variety. You know, we're telling them to moderate. We're telling them, okay, don't do this, don't do that. I always tell my women in the clinic, go for variety. When you look at beans, oh, patient is diabetic, you say, okay, eat beans, eat unripe plantain. When I talk of striving for variety, there are different methods to prepare a meal. So it doesn't get boring. If you give somebody beans and you're saying only beans and stew, the person will get bored. But beans could be cooked in different ways. You can make it beans pottage, you can make moi moi, you can make akara, you can do so many things with beans. So strive for variety. It takes away it being boring. Keep active. Exercise before and during pregnancy. Take basic walks, swimming. Park cars further away from destination to encourage walking. Our able prof mentioned it when he was speaking earlier. Some of us, we are guilty of it. We park our cars in front of our offices and just walk in. Sometimes park it at the gate and stroll to your office. You know, it will help us to do some form of exercises. Next slide, please. Start pregnancy at a healthy weight. We always advise our mothers, our patients, our clients, if you're overweight, lose weight before pregnancy, because in pregnancy, there's this tendency to add a little weight so that at least you'll be within the normal rate. Modify your diet. Do not gain more weight than recommended. There's a condition we call in pregnancy. We call it, it's one of the minor disorders of pregnancy. We call it pica. Let me explain it as being longer throat. Pregnant women have a lot of longer throat. You know, so some of them, they go for these things that are not too healthy. You see a woman, she wants to eat a PT 3 times a day. It's not too healthy for her. So in such cases, you modify those things so that you will not add weight so much. Get tested for diabetes after pregnancy. Get tested for diabetes 6 to 12 weeks after the baby is born. Because you know, one of the complications is type 2 diabetes. So you have to keep checking. Check your blood sugar level so that you will not progress to that. Next slide, please. In conclusion, gestational diabetes is a type of diabetes that is first seen in a pregnant woman who did not have diabetes before she got pregnant. It usually shows up in the second trimester, most probably between 24 to 28 weeks of pregnancy. It occurs when the body cannot make the extra insulin needed during pregnancy. Risk factors such as prediabetes, race, personal history of gestational diabetes contribute. It can be controlled using a healthy diet, exercise, insulin, and oral agents in some cases. Complications to the mother and baby include big baby, premature delivery, birth trauma. Thank you for listening.
That was very wonderful and a breathtaking presentation by Mrs. Erela Lale Elichi. Once again, let's put our hands together for her. Okay, I've been told to move straight to the next presentation, and thereafter we'll take questions and answers. So we'll call on our next presenter that will deliver COVID-19 and diabetes, the myths, the facts. So we also have a presentation to make. Please, Mrs. Elara, you have section before you leave. Okay, let's call on the chairman, Association of Female Medical Laboratory Scientists of Nigeria, River State branch, to do this presentation for us. You're welcome.
Mrs. Alera Elechi. Elera Lale Elechi. Thank you so much for coming out to do us proud. We really appreciate you. And so on behalf of the Female Medical Laboratory Scientists of Nigeria, River State Branch, we are here to present to you a award of recognition presented to Mrs. Elera Lale Elechi as resource person during the World Diabetes Day celebration workshop tagged Access to Diabetes Care, if not now, when? This day, 18th November 2020, held at College of Health Science and Management Technology Auditorium, Port Harcourt. Signed, Seriza Jeremiah. I have the singular honor of making this presentation directly to you. You're welcome.
Are we set for the next presentation? Please, let's put our hands together as we call on Dr. John Omuli to take us on the next presentation. You're welcome, sir.
well prepared.